Thank you so much. And I am so pleased and privileged this morning to introduce our plenary speaker, who is a accomplished senior scientist, researcher, teacher, advocate for human rights, for children, for adolescents, and the field of mental health prevention. Dr. William Beardslee, who currently directs the Bear Prevention Initiative at Boston Children's Hospital, is a senior research scientist at the Judge Baker Children's Center and the Gardner Monks Professor of Child Psychiatry at Harvard Medical School. Dr. Beardslee's longstanding research interest has centered on the development of children at risk due to parental adversities, such as mental illness and poverty. His work has focused on the ways in which self and shared understanding help individuals and family cope with these adversities. He has studied resilience in survivors of cancer and in children of depressed patients, which has led to the development of interventions for families facing depression that have been used widely in Finland, Holland, Costa Rica, Australia, and in other Scandinavian countries. In our own country, Dr. Beardslee has adapted these principles in teacher training and in empowerment programs that have been used in Head Start and in early Head Start, called Family Connections. In Boston, he directs a multi-site study on the prevention of depression in adolescents. This work has demonstrated sustained preventative effects for more than 32 months after enrollment. Very interested in learning more about that. He is also an IOM member, has served on 2 IOM committees. He is on the board of the Rosalind Carter Mental Health Task Force and numerous other boards, and has written over 225 scientific articles and 2 books, and received numerous awards, including the Blanche F. Idelson Award of the American Psychiatric Association for outstanding published research contributing to the mental health of children, among many other awards. Today, Dr. Beardslee is going to deliver a plenary titled Mental Health Promotion and Prevention in Primary Care, an idea whose time has come. And I say I couldn't agree more. So it is my great pleasure to introduce Dr. William Beardslee.
Thank you very much for that kind introduction. It's a great honor to be here and to be part of this program and to be attending this great organization. It's been a wonderful event last night and again, wonderful today. I've known Richard Frank for many years and I thought he really set up what we need to be thinking about under healthcare reform. When I was in college, there were lots of billboards and people writing on, all kinds of slogans. And I was thinking about it today because I think in my career I've been trying to practice collaborative, integrative family care for depression, although I wouldn't have called it that. And the saying that I was thinking of in college was one which said, 6 months ago, I didn't even know what an English major was, and now I are one. So I may not have known what to call it, but I hope you'll take it as very much in the spirit of the conference. And much of what I say, many of you already practice. Much of what I'll be talking about you already know, but hopefully it'll be useful to review some of it, and I'll certainly leave some time for questions. My title comes from an article and I was interested in talking about Dr. Block and the mentors. One of my great mentors was Julie Richmond, who was the first medical director of Head Start, was Jimmy Carter's Surgeon General, and was my chief at Children's Hospital when I trained there, and he wrote an article entitled Developmental Pediatrics, an Idea Whose Time Has Come. I've taken it to Mental Health Promotion and Prevention in Primary Care, an idea whose time has come. We live in times of great challenge in terms of we have not recovered from the Great Recession. There's a widening gap between rich and poor that undermines our health and our democracy, and we are stuck as a society in finding values in common to pass legislation, and we have many troubles abroad. On the positive side, we have better research, better science, and in many ways than ever before, we have an awareness that we need to move things forward. There are many examples at this conference of things that work, and many in other places. Richard talked about some of those yesterday. We have also a much greater awareness that we need to get things right from preconception on through the first 5 years of life in order to have any chance of narrowing health disparities and wealth disparities. And I think we have three developments that certainly give me a great deal of hope. First of all, the Affordable Care Act, with its emphasis on prevention and collaborative care, and on, collaborative care and family care. I think the second is we have the passage of the parity legislation, which will give us another lever in trying to achieve justice for those who suffer from mental illness. And thirdly, we have lots of innovative state, local, and community programs from which we can learn a lot. And we have a very strong science base. So I thought I would then just share with you some of the ideas that we've had about integrated care for depression. I don't have any disclosures to make. I don't receive any money from pharmaceutical companies. I do consult to various state and local governments and work occasionally with SAMHSA. So in terms of three first principles as we try to think about family care for depression, the first comes from James Agee. This is a book that Agee wrote about sharecroppers in the South in the 30s. The child is the bearer of whatever the future shall be. At this center, his incomparable tenderness to experience, his malleability, the almost unimaginable nakedness and defenselessness of this wondrous five-windowed nerve and core. Agee captures the promise, the magic of children and what they bring, even in very difficult circumstances. And that's what our North Star, our orienting principle should be. Secondly, I think all of you believe it, but I'll say it again, health care is a basic civil right and a basic human right. It's not negotiable. And I would say mental health care is a basic civil right and a basic human right as well. And finally, something that I've really come to more recently, and that is a very strong interest in implementation and dissemination. Most of that came from the work we've been doing with the IOM, but if we believe in a democracy, as all of you do, as I do, then we have to be able to offer everyone the same quality of treatment, the same kind of treatment, evidence-based treatment, evidence-based prevention. That means we have to take the things that many of you are doing that are very innovative and figure out how to disseminate them widely and effectively with proper training and with proper measurement. So I've come to believe that a third key principle in our work in healthcare has to be effective implementation and dissemination. Now, again, going back to my mentor, Julie Richmond, and of course I work in the area of depression. There's a lot of interest in molecular genetics. There's a lot of interest in, gene-environment interactions, all kinds of things. But I think a fundamental point is that the pediatrician can regard the family as carrying the chromosomes that perpetuate the culture and also form the cornerstone of emotional development. That's why we need to be concerned about both diversity and about families. And finally, as we launch into healthcare reform, if you always do what you've always done, you'll always get what you always got, okay? We need change, we need to move forward, Albert Einstein, I think, captured that very well. And healthcare reform must challenge existing paradigms and develop new paradigms. That's much of what this organization has done and must continue to do. Now, what should a healthcare system look like that fully meets the needs of families, incorporates prevention and treatment, and reflects cultural competence and cultural humility? And I'm going to cover in my talk briefly our Institute of Medicine prevention report. We did a second report on parental depression. I'll talk a little bit about some of the preventive interventions for parental depression, and I'll talk a little bit about policy opportunities under the ACA and practical implications. So the themes are very much in line with the conference. That is family-centered care, prevention of mental illness and problem behaviors, and population-level impact. And also in line with the triple aims of the ACA, improving the experience of care, improving the health of populations, and reducing costs. I'm sure all these PowerPoints will be available on the web. At the end of the PowerPoints are a set of references. There's a very good article by Don Berwick in Health Affairs about the ACA that I think is useful. And then coming then to the IOM does its work when it makes recommendations by appointing a committee of people, giving a charge, and then the committee scrutinizes the evidence over 3 years, writes a report. That's then torn apart by 20 other scientists. We edited and came out. So here's our committee, which started in 2007, published the report in 2009, and then we've convened once a month since, and recently founded a forum on implementation and dissemination at the Institute of Medicine, which I co-chair. The two people at the lower right are myself and Ricardo Munoz, a great psychologist. Interestingly enough, we both work in the prevention of depression, and we're the only two members of this committee who were also on the committee that wrote a report on the prevention of mental illness that came out in 1994. And I think one of the biggest differences between 1994 and now is that we know that most of the major illnesses, mental illnesses of adulthood, have their origins in childhood. Early onset, 3/4 of adult disorders had onset by age 24, half of them by age 14. First symptoms occur 2 to 4 years prior to diagnosable disorder, and they're common risk factors for multiple problems and disorders. I think that we have to have a developmental perspective on families, on children, and on adults, and we have to think about moving to the prevention of mental illness from the beginning.
Sorry to interrupt.
All right. If I'm not being clear, if you can't hear me, okay, but raise your hand. I'm not usually hard to hear, and please let me know. So we need to be thinking about that. I was thinking about this in relationship to Richard's talk yesterday, and the fact that another kind of outcome, in addition to functioning in adulthood that's of great importance, is really functioning in parenthood. And we ought to be thinking about, not only when we're dealing with depression, treating the depression, but also really helping the parent be an effective parent and looking at those outcomes, because I think that's where we will have our largest impact. Mental health promotion is not simply the absence of mental illness. This is a definition we used in the report that came from the WHO. Mental health promotion aims to enhance individuals' ability to achieve developmentally appropriate tasks or developmental competence, a positive sense of self-esteem, mastery, and well-being, and to strengthen the ability to cope with adversity. And this is probably the most widely cited diagram from the Institute of Medicine. You may not be able to see it very well, but across the top are developmental epochs: early childhood, early adolescence, et cetera. And then across in the bands are the kinds of interventions that have a strong empirical base for use. So certainly from preconception on, good prenatal health care, good health care, after birth programs like nurse home visitation, high quality center-based care, early Head Start, moving into the phase of childhood. There's lots of evidence about academic enrichment and about social skills training. Moving into adolescence, there's very good evidence about substance abuse prevention. I think there's some good evidence about depression prevention. And there's even some evidence now that we can stave off the worst effects of first onset schizophrenia by a combination of family and individual therapy, cognitive behavioral therapy, and occasionally low-dose antipsychotic medication. And then across the bottom are three themes that cut across all the work. One is a strong evidence base for interventions that target parental adversity, parental mental illness, divorce, and so forth. A second is community interventions that strengthens communities, and a third is policy interventions. So in terms of implementation, there's strong across-the-board evidence for family-based prevention strategies. There's the need to move from efficacy to effectiveness trials. Implementation research has highlighted the complexity of that and the important role of community. Cultural humility and cultural and linguistic competence are essential for implementation. And to go back to what I said before about implementation and democracy, if we think about the settings where any of you work, but certainly where I work in Boston, they're very diverse, different languages, different cultures, different levels of adjustment to the dominant culture, and the sensitivity to the cultural issues will really determine what kinds of outcomes we get. Now, the recommendations from that report were that we need to put knowledge into practice, we need to make our programs come alive based on evidence, and we need to continue rigorous research, and not just the kind of large NIH-funded research, but research daily on what we do. Again, much of what is the subject of this conference, integrative care. The scientific foundation has been created for the nation to begin to create a society in which young people arrive at adulthood with the skills, interests, assets, and health habits needed to live healthy, happy, and productive lives in caring relationships with others. We have the science on our side. We have a whole array of very effective preventions. We need to figure out how to implement them. And I would say, certainly in this conference, but in many other places, we also need to have a broad public health perspective and to look very hard at the big public health risk factors that drive so much of outcomes. In the IOM report, one factor lurks in the background of every discussion of the risks for mental, emotional, and behavioral disorders and antisocial behavior: poverty. Although not the focus of this report, there is evidence that changes in social policy that reduce exposure to these risks are at least as important for preventing mental, emotional, and behavioral disorders in young people as are other preventive interventions. We are persuaded that the future mental health of the nation depends crucially on how collectively the costly legacy of poverty is dealt with. So we must address poverty. Now, I'll talk a little bit about depression specifically, just to give you some illustrations of some of the ways we think about prevention. This is a standard public health slide, which each of these factors listed is supported by empirical evidence. On the left-hand side, these are factors specific for depression: an extensive family history of depression, a history of prior depression, a depressogenic cognitive style. That would be like Eeyore in Winnie the Pooh, who always sees the bad things that might happen. And bereavement is a very potent risk factor for depression. But on the right-hand side, exposure to trauma leads to more cases of PTSD, but it also leads to a lot more cases of depression. So does poverty. Children raised in poverty have a several-fold higher risk of depression than those not raised in poverty. Social isolation, job loss and unemployment, family breakup, loss of community, dislocation, refugee status, and we've done a large project with the Blackfeet Nation in Browning, Montana. They convinced me that historical trauma is a very potent risk factor in depression in some of the families we deal with. So again, in the references, there are two big meta-analyses, one by Kim Kuipers from Utrecht and the other from Sally Mary from New Zealand, both of which show that if you look across the studies on the prevention of depression, the evidence is very strong. And that probably if we were able to implement depression prevention strategies widely, we might be able to prevent as many as 20% of the episodes of major depression. And when you think about mental illness, it's so rare that we can prevent mental illness, and here we have a good shot at it. Now this next couple of slides comes from the report on depression in parenting. We had a family physician on the committee, and we very strongly endorsed collaborative care models in the treatment of depression. I think just to review, again, speaking as a psychiatrist, we have some of the best treatments in medicine, and indeed some of the best treatments in mental health for depression. And it was interesting that Richard's slide and illustration about cost effectiveness was about the treatment of depression in collaborative care, and he said these are outcomes as good as most of the health outcomes we get. So the treatment evidence is pretty powerful. A variety of safe and effective strategies exist for treating adults with elevated symptoms or major depression, including cognitive behavioral, interpersonal, medication, and there's now good evidence about meditation and alternative therapies as well. A variety of strategies to deliver these treatments exist in a wide range of settings. Strikingly, hundreds and hundreds of studies of treatments of depression in adulthood, but almost none of them report whether the people are parents, and almost none of them report whether the treatment has an impact on parenting, even though that's the most important thing that people who are parents are doing, and most people who are parents would say this is the most important thing that I'm doing. So more attention to the effect of the family in treatment is warranted. And there was one big study done by John Rush and colleagues of treating people to remission. So they had an algorithm with a cognitive behavior therapy and a bunch of medications. And Myrna Weissman looked at the group of people who had children and then compared those who got treated to remission and those who did not get to remission, and found much better outcomes in the children in those who were treated to remission. It's not a, it's a correlational study. It was not designed to look at the outcome, but there are a number of studies underway now to try to look at that, I think, with promising results. And the kinds of things that we should be paying attention to in treatment are that when people have a choice about treatment, they do much better. And so offering a range of treatment makes a big difference. Treatment tools and strategies to deliver these treatments should be flexible, efficient, inexpensive, and acceptable to the participants, available in a wide range of community and clinical settings. Jeannie Miranda has shown that if you adapt standard cognitive behavioral treatment for minority populations, you can get the same results. Ken Wells has shown in family practice, primary care practices, that certain strategies to increase the recognition and treatment of depression work. Many of you have been engaged in that work. It's a story, it's one of the success stories in terms of what we know. Now, we felt strongly that whenever someone who is a parent is identified as depressed, we ought to think about interventions to help the family as well as treatment of the parental depression. And I'll say something about some of the practical implications about that later, but there were a series of promising preventive interventions. Most of them involved treating the parents, providing help with parenting, using a two-generational approach, and also some directly involved the children. And it's important to remember that depression prevention sometimes occurs as a side effect or as an outcome from a different kind of intervention. Rick Price did a very innovative jobs retraining program in Michigan after a lot of unemployment in the 80s in the auto industry. Started out as an individual intervention, quickly became a couples intervention, and it found not only that the people who got the intervention were more quickly reemployed, but also that they had much less depression. Erwin Sandler did a very elegant intervention for parental bereavement. Parental bereavement affects about 4% of children in the country, and showed results now 15 years later of much better mental health and health outcomes, much better substance abuse outcomes from this intervention, and fewer cases of depression in the parents. And interestingly enough, the mediating variable between delivery of intervention and positive outcome was an increase in parenting. So we have some good evidence from other studies, and then we had a series of studies that we cited. I'll talk a little more about Family Talk, which is a public health prevention strategy for depression. And in the references, I'm part of a team that did a foresight replication of Greg Clark's preventive intervention for kids at double risk for depression because they had parents who'd had depression and they also themselves had symptoms of depression or had prior depressions. We did a single-site trial in Portland. We then did a four-site trial involving Judy Garber in Nashville, David Brent in Pittsburgh, Greg Clark in Portland, Oregon, and with Kaiser, and myself and my team in Boston, and have been able to show, I think, two things that are striking. One is that we do actually have the capacity to prevent episodes of major depression. We had a paper in JAMA showing strong effects at 9 months. We have a paper that I've cited that I'm the first author on in the archives, what's called JAMA Psychiatry at 33 months with a sustained preventive effect, and we'll be presenting later this month in San Diego at the Academy of Child Psychiatry the 60-month data, which shows, again, the prevention of episodes. The other thing that's really striking about that study is that if the parents are acutely depressed at the time of enrollment, then the interventions don't work. And we're engaged now in trying to, but that's something to think about when you're working with depressed parents and you're working with kids, that if the parents are depressed, it may have a large impact on the ability to take up interventions, and so you need to be thinking about those strategies. Bruce Compass has an elegant intervention for family groups, some sessions with kids, some sessions with parents, some sessions together, really skill-based coping intervention, and he shows dramatically fewer cases of depression in the kids 2.5 years after enrollment. So again, depression prevention is possible. Ricardo Munoz, who was at San Francisco General for many years, developed an elegant talking intervention for postpartum depression, very widely used and very effective. And I would also say, as we think about broad public health principles, I had two mentors. One was Julie Richmond, the other Leon Eisenberg, the longtime head of social medicine at Harvard, but had been chair at Mass General when I was a resident there. And he wrote a famous paper which said, "A friend, not an apple a day, will keep the doctor away." And the key point is that social relatedness is in many ways the key driver in preventing depression and in ameliorating. And I think about it particularly in the postpartum period, where probably many of the most effective interventions are going to be psychosocial interventions. And we ought to be thinking along that. There's a famous study from England, the PRAM study, in which they paired mothers who had just had babies, newborns, by getting to go out and wheel their babies in prams, strollers, or baby carriages, and they showed less depression in the people who were in the active condition. Well, it's not just wheeling a baby carriage; it's a social interaction. It's being outside. It's interacting with each other's babies. But again, those are things that are fairly low cost, and we very much need to think about. So, again, across both reports and in a variety of different risk situations, very strong evidence for the value of parenting programs. So then special opportunities and challenges in working in trying to think about prevention, developing systems that can be two-generational responses to parental depression.
Can't hear you.
Okay. Special opportunities and challenges, developing systems that, can you hear me now? Developing systems that can give two-generational responses to parental depression. I've had this conversation with Richard many times. It's been, as a psychiatrist, very difficult to get reimbursed for doing preventive interventions with families when because you're not treating illness in the child so you don't have a diagnosis, but there's a huge amount of evidence that this is a very valuable way to go. Responding to the needs of vulnerable populations, especially low-income, culturally and ethnically diverse families, responding to families experiencing depression along with other comorbidities, medical illness, substance abuse, anxiety disorder, and then developing complex initiatives that build on collaborative, integrative, and comprehensive service models. I wrote this before I came to the conference, but collaborative, integrative, and comprehensive service models, that was very much what we said in the IOM report. And then what are the core challenges in mental health prevention? There's a lack of a home for prevention. It's not owned by any one discipline. We founded the Society for Prevention Research. I'm an active member, in part to try to draw attention to this. There's lack of a trained workforce. We've had a lot of talk about infrastructure and workforce. That's very much true with the prevention issue as well. There's a lack of infrastructure to support the introduction of new programs. One of the things we need to know is treatments are changing all the time. Preventions are changing all the time. We need to think about a flexible structure that allows that kind of introduction. There's a lack of a payment system. And historically, certainly within psychiatry, there's a lack of attention to prevention as opposed to treatment. We have the inverted pyramid in child psychiatry. We spend a huge amount of money on relatively few very ill kids with very serious illness. We spend almost nothing on prevention and not nearly enough on screening and treatment of things we know how to do: depression, ADHD, anxiety, etc. So then I'm just going to give you the flavor of one preventive intervention we've been involved with. That's Family Talk. It's a preventive intervention I devised with my colleagues in the late 80s that really, we went through the standard, public health paradigms, did a risk study, looked at resiliency, piloted 2 public health interventions, did a big randomized trial, which had positive outcomes, got high rankings in the National Registry of Effective Programs, did an adaptation for African Americans in a randomized trial in Dorchester, the Family Core Project, did narrative reconstruction, and since 2000 we've been involved in trying to understand something about efficacy to effectiveness to dissemination. And I should begin by saying that what we found was that depression really destroys the possibility for families to have conversations, to see themselves as part of narratives, and to be able to make sense of things together, because it's an illness that has a profound family effect but isn't recognized and talked about. So the intervention is really about helping the family uncover strengths and be able to have a conversation about depression and how to overcome it. And it's very much built on principles of resiliency. In our risk studies, we, like everyone else, found that there are higher rates of depression in the children of parents with mood disorders, but many of them are quite resilient. And my work has really been guided by a resiliency perspective. Here we are in Washington. We've had many anniversaries. Last year we had the anniversary of the March on Washington, and this year we've had the anniversary of the War on Poverty, the Community Mental Health Act. I worked in the civil rights movement in the 60s and the summers from college. I'd grown up in Atlanta, and then when I was a resident, I went to Leon Eisenberg, my mentor in chief, and I said, "These are the healthiest people I've ever known in my life." He said, "Why don't you go and talk to them?" So this was the old days. So I took some months off from the residency, went to the South, interviewed these people, and wrote a monograph about it. The Way Out Must Lead In, Life Histories in the Civil Rights Movement, which the theme was really both these people's extraordinary strengths, but also that they were both on an outward journey of transforming the South and on an inward journey of self-understanding. And their resilience consisted of being able to be very angry and keep working. They were quite courageous. Many of their lives were often at risk. They were very much activists and doers, registering voters, founding organizations, setting up Head Start centers, not passive. They were deeply committed to relationships, and they had a very strong sense of self-understanding, and that's sort of guided all my work since. The lead historian in that book was John Lewis. He said, being involved tended to free you. You saw segregation, you saw discrimination, and you had to solve the problem. But you also saw yourself as the free man, as the free agent, being able to act. After what Martin Luther King Jr. had to say, what he did as an individual, you couldn't feel alone again. It, being in the movement, gave a new sense of pride. It was a new sense of identity, really. You felt a sense of control over what was happening and what was going to happen. So I had I learned a great deal from John and from the civil rights workers, and I think those principles are very much what's guided our work in the prevention of depression. Now, in terms of looking at resilient youth, we did interviews with those folks in our studies that were resilient in the face of depression. 3 characteristics. They're very much engaged in accomplishing age-appropriate developmental tasks, school, work, church, deeply committed to relationships, and they had a strong sense that they were aware of their parents' illnesses and they were not to blame for them. So very much the sense that they were free to go on with their own lives. And similarly with the parents, they were deeply committed to parenting despite depression. They had an openness to self-reflection, and they were committed to family connections and the growth of shared understanding. And one of the people I talked to, Kate, said, when I asked her, what should we do to try to help others who are growing up with parents who are depressed? First, somebody should explain why people get depressed. You really don't know what it is and if it can happen to you. You don't know why your parent feels that way. You don't know if you're going to feel that way yourself or how to manage it if you do. If someone has a disease, you want to know how he or she got it, how you can prevent it from ever happening to you. Otherwise, you have fear. You can't trust something that doesn't have an explanation behind it. And her mother said, after a 20-year battle with depression, it's important for kids to be brought up in a house where they can express themselves. In my childhood, we never had that. It was difficult when I grew up. Bad feelings were something I feared, something I suppressed. My kids can be open. If there's a problem, we talk about it and we try to solve it. So I think really, and I will say this in the august company of all these great academicians in the room, I think really good preventive interventions are systematized common sense. And so what we did in the family talk intervention was essentially put together a way that families could have a conversation. Take a history with both parents in the room if they're 2 parents, emphasize both the positives and the difficulty, put the child, ask one what they've been through, then ask the other. It's amazing, even with well-educated people, having not talked together about what the effect of a depression has been on them or on their families. Put the child in the room figuratively by saying, what do you think this has been like for your child? Then do some psychoeducation. And the key with this intervention is, the science is pretty clear. Depression's a biological illness. It's no one's fault. There are treatments that are available. There's things that one can do to encourage resilience. The key is not that, which all of those things are true, but how you pair that information to the actual life experience of the family. So one of the families we worked with, the mother said this, I have a nice routine with my 12-year-old. He comes home from school, he has a snack, he does his homework, and we play a game together. But when I'm depressed, I just sit him down in front of the TV and call his father and say, come home early. In other words, the boy's experience of depression was the complete breakdown of the routine in the family, all kinds of different things. And that was then what we needed to work with and try to reestablish. And when the mother saw, even with depression, she could reestablish those routines, she was able to, and it really made a huge difference. So that's the family talk story. And the other thing that we did was to do long-term follow-ups. We went back to these families. We had 2 kinds of follow-up. They could call us anytime if they were in trouble. And we scheduled 6 to 9 month follow-ups on a regular basis. Now, if we think about depression as an illness probably like rheumatoid arthritis in the sense that people have it, they're going to have crises, you use a disease state management approach, but you don't wait until people get really ill. You see them regularly. And the families were so grateful that we did these strategic follow-ups and asked them how they were doing. This is what you told us last time. So I think follow-up has to be a crucial part of care. 3 randomized trials, high rankings in the National Registry of Effective Programs. I'm very pragmatic, so we wrote a book for families called Out of the Darkened Room and tried to put these principles right there. What might go into a successful family meeting? Pay attention to the timing of the meeting, gain commitment to the process, begin by identifying specific major concerns and addressing them, bring together and reknit the family history, the family narrative, plan to talk on more than once, and draw on all the available resources to get through depression. So that's sort of the intervention. In the randomized trial, it was paired with the standard public health intervention of having a boring, aging white male give lectures about the topic, namely me. and that intervention actually had some value too. And I mention that because I think that we get involved in intervention development and we have all these great ideas about it, but in the field, one ends up using a lot of flexible strategies and can't do a large intervention all the time. So again, we followed all the families for 4.5 years, many of them for as long as 10 years, and really the making sense of depression and the making sense of how to mature and grow despite depression is an ongoing interactive process. What we were trying to do with these families was encourage their problem solving. We saw over time that the families had healers who emerged from within, who were able to help the person with depression, sometimes the person with depression himself or herself, and we very much came to understand that one needed to understand depression anew again and again, both because the children developed and because the illness often came back. But again, it was a great privilege for us to be able to follow these families and learn from them. And then since then, we've been engaged in a variety of trying to understand implementation dissemination, but also we put this information out there and let people use it as they wish. I mentioned we did a randomized trial with African Americans. We also did one with an open trial with Latinos. I happen to be part of an international collaborative group, and this intervention was used in countrywide programs in Finland, Holland, Norway, Sweden, Costa Rica, and Australia, so I got to have some sense about how those healthcare systems perform. And again, I'm going to try to be very brief to leave more time for questions, but I did want to just make one comment about working in Finland. Dr. Tutti Salantaus really did a countrywide program for children of the mentally ill, and from the beginning, she wanted to change child mental health from a diagnosis and treatment system to a health promotion and prevention system. And from the beginning, she said this will take 10 years at least. And Finland's a country that's very friendly to preventive interventions, many countrywide preventive interventions. But she started that from the beginning, and then she quite rightly said we don't need 1 or 2 interventions, we need a family of interventions so that we can pair and mix and match the interventions to different circumstances. She, in the first 2 years of the project, did nothing but train master trainers. She now has people trained to work in these ways in every health center and every mental health center in Finland. And the other thing, speaking from a public health point of view, we do all this work on very precise measurements of depression, a focus on depression, et cetera. The minute you go out in the field, people will use the intervention for whatever walks through the door. They're not going to say, I'll do it for depression, but I won't do it for something else. So you have to figure out how to be flexible. She applied it to alcoholism, parents with incarceration, parents with major medical illness. And again, she devised a much shorter intervention that's much more widely used. We did an adaptation in Boston with a bilingual, bicultural team, our Latino team at Children's Hospital. And just a word about this. That in very strong family orientation in Latino families, more of an orientation to the other. In working with immigrant families, a very different kind of separation, because many times some of the key people in the family are in the country of origin, not able to be in the family meeting, so you have to think about that. And then at least in Boston, or in Massachusetts, we have this law that everybody has to be taught in English. So what happens is the kids go to school and they learn English, become fluent in English. The parents often are not fluent in English, often don't speak. And then how do you have a family meeting when people are, well, the language plus is soluble, but the different cultures really clash, and you need to pay attention to that. One of the things we found in this trial was that the children were very curious about the immigration journey of their parents, but the parents hadn't told them anything about it. And so we added an immigration narrative to this. And we're able to show the same kinds of results, same magnitude of changes in the open trial that we had in our randomized trials. And finally, I think it's important that we think about what our aim should be. And what our aim should be is really helping people heal from depression. So this is what some of the Latino women that we worked with said, what helps parents cope with depression. Focus on the children, visualizations, envisioning a better future, prayer, songs, religion, church, community, spiritual healing, support groups, helping others, sharing information, focus in the present, not giving up, alternative medicine, and humor. I won't attempt the Spanish, but I would say these are universals. These are what help people get through depression. So now we have this training for Head Start personnel, that's Family Connections. We have a website for web-based training. Again, it's another aim to try to do dissemination. All this is available for free. That's the home page. That's the page of the course. It's 8 modules. We added an additional module on skills. Anyone can take it. If you're a social worker and you take it, you get 4 hours of CME credit. We're exploring various ways to try to do web-based training. These are my collaborators from Finland who are great people, and we have a whole list of international collaborators and resources. And then I think I won't talk very much about the ACA and the opportunities, because I think that Richard covered that pretty well, but we did a 5-year project with the Urban Institute trying to look at policies. If you want to talk about a group at high risk, talk about mothers who are poor of young children, okay, and add ethnicity and race. So we were trying to think about how could we get services to these mothers. At the time we started this, only about 60% of mothers had health coverage. Not too hard to get coverage for very poor young infants, but it's very hard to get coverage for their mothers. That's going to change under the ACA. So we did 3 years of looking at best practices, including some collaborative care practices, and then we did 2 years with federal policymakers. And where the federal policymakers come from HUD, WIC, Head Start, food stamps, that's where the mothers are. And basically, as Richard said, there's additional coverage, there's accountable care organizations, patient-centered medical homes, health homes, medical care management. Now, just in terms of practical information, I think you probably all know this and practice it already, but I'll just go through it because I think it's useful to think about what are the practical implications. Parental depression is prevalent in family practice. Parental depression, when recognized and treated, can have a multiplier positive effect on the family. Available evidence confirms that we should both treat parents and ask them how their kids are doing and support their parenting. Screening and referral are useful when available resources have been identified. The U.S. Preventive Services Task Force recommends screening every adult for depression once a year. If resources are available, we would agree with that. The PHQ-2 and the PHQ-9 are reasonable instruments, and attention to the system in which primary care occurs and its ability to deal effectively with depressed parents are as important as any particular intervention. I'm sure you all have solved all those issues. When we were working in the field with the Urban Institute, one of the things that was very clear is it's not very useful to try to build an alliance with another organization in the midst of a crisis. You need to have if you're working in a primary care practice and a behavioral health practice, you need to have built that alliance ahead of time. Co-location is one of the ways to do that. There are other ways to do it, but it's building the alliances and the structure in a time of non-crisis. Working with parents who are depressed as parents first is essential. Elicit the parent's concerns about himself or herself and about the children. And brief parenting interventions and referral of children for evaluation are helpful. And follow-up, watchful waiting, is incredibly important with this population. So, again, to leave some time, I believe very strongly that there's a family narrative that involves a present, a past, and a future, and a culture, and that children are the embodiment or the sort of focus of that narrative. That narrative is often very disrupted in parental depression. We need to get families back on track, pay attention to that narrative. And of course, the other big issue in working with parents who are depressed is that many of them believe they've irrevocably harmed their children, which is not true, but can be dealt with. And I think a primary care physician is in the best position to provide family-centered preventive care for depression and to facilitate treatment. We did, the group that did this Urban Institute project just has on the web, we wrote a guide for frontline healthcare workers. So not for the people like you who are all very sophisticated, but again, the WIC, food stamp, Head Start kinds of workers, depression more than the blues, a toolkit which really goes through in lay language what depression is, thinking about resources, thinking about treatment, thinking about risks and dangerousness. And again, that's available for free. I continue to work with my colleagues from the Institute of Medicine. Ricardo Munoz and I wrote a paper in the American Psychologist. Major depression can be prevented. I think you can figure out what that's about. We've been more and more interested in poverty and ways to ameliorate poverty. Tony Bigland, who was on the committee, is particularly interested in nurturing environments. How can schools be configured? And again, we're all interested in how to incorporate prevention practices under the ACA. We were able to get a forum sponsored by Academy of Pediatrics, the American Psychological Association, CDC, NIMH, and a bunch of other government and non-governmental agencies on the dissemination of health promotion and prevention strategies. Our first conference was last April, and that one was on strategies for effective family-focused treatments. So in the interest of time, I'm going to show you the questions that plague me, and I try to keep working away at. What degree of interventions in what sectors is necessary to significantly change outcomes? We're research scientists. We ought to be thinking about what's the dose of anti-poverty programs that we need to do to move this needle and make a difference. What are the best policy, payment, and clinical strategies for family-based mental health prevention in primary care? Where, if we have limited resources, do we put the incentives to make this happen? Now, two other questions really worry me. How can systems both make enduring improvements and deal with the enormous pace of change and regulation? I'm a child psychiatrist. In the last year, we have DSM-5, which is a totally new diagnostic system. We have ICD-10. We have a whole new coding and billing system. We use PowerChart, which is not very user-friendly for behavioral health. And we've got huge initiatives at the federal and state level. And as you know, in Massachusetts, we've had longer experience with coverage for all, and we're a little bit further along about various kinds of rewards for primary care and pediatric practices, but there's just an enormous pace of change. And I do worry about initiative fatigue, because every meeting I go to, there are all these new initiatives that are going on. And you know, the question of what can you do and how do you keep your eyes on the prize and stay focused when there's all these distractions? I think international research can teach us a great deal. What characterizes countries that invest heavily in young children and their parents? What can we learn that helps us make the same investments in family leave, in child care, in education, that these countries that have much better health outcomes at a fraction of the cost have? And how can we address equity, scientific equity, in the study of vulnerable populations? We must come to see that the end we seek is a society at peace with itself, a society that can live with its conscience. Martin Luther King, Alabama, 1965. Thank you very much. And I don't see any microphones, but I would be glad to take questions.
There are microphones. Sorry about that. And there's the first question.
Yeah. Thank you, Dr. Beardslee.
Right, and I can't see you well because of the light there, so just be sure and speak clearly.
I will try to. Thank you very much, Dr. Beardslee, for this really comprehensive overview. My name is Barry Jacobs. I'm a psychologist and family medicine educator outside of Philadelphia. And I guess I especially liked your emphasis on the social context, poverty in particular. I am not sure that primary care, I've worked in primary care for 20 years, I am not sure that's the best context to prevent depression. And I am wondering what can be done to move some of these prevention efforts out into the community, not just social service agencies, but other institutions like education, churches, because that's where I think prevention is most likely to occur.
So first of all, I absolutely agree with you, okay, that we should be using a multi-front strategy, and we should be placing information about prevention and indeed prevention programs in schools. The Greg Clark work that I cited originally started as in schools and can be widely used in schools. I think churches are another very good venue. I think there are two issues. One is really raising the public consciousness about the value of prevention, so people want it. And the other is helping people see that in spite of many competing agendas, it's really worth doing prevention. I still think within medicine, primary care is the best place to start, and certainly the primary care mental health system in Massachusetts is pediatrics and primary care, family practice. That's where much of the behavioral health practice is, and so that's the place to start.
Over here.
Hi, my name's Tillman Farley. I'm from Salute Family Health Centers in Colorado. You used the word or the phrase historical trauma, and I'm interested to what degree is that a sort of polite way of saying ongoing societal racism?
Well, I mean, I think they're different. Let's be clear about terms. I think that the term historical trauma, when we went to the Blackfeet, the first day we were there, they did a day-long presentation to us, and they said, you cannot possibly understand depression. And they had asked me and a colleague to come and help in the early Head Start around postpartum depression and other kinds of depression. You can't possibly understand depression in this culture without understanding historical trauma. There's no question that the federal government committed spiritual genocide against Native American people in the 19th century and engaged in practices like the Carlisle School and other things that were just barbaric. So that's the fact of historical trauma. I think that I myself, having grown up in the South and worked in the civil rights movement, believe that we have lots of racism still within the society, and we need to be able to deal with it. I do think we've made a lot of progress, and I think we just need to be very careful in our language so that we can frame things as problems to be identified and solved. That's all.
Hi, Will Lusenhoff. I'm a clinician and faculty in the Department of Social Work at the University of New Hampshire. The one question I have is when I teach my students and I talk with my clients, I often frame things like anxiety and depression around the deprivation of a social experience. And I'm wondering if you could comment on this new field of interpersonal neurobiology, where we're finding that the brain is inherently a social structure. And so I tell my clients and my students that being social is like oxygen. And when you don't have it, you experience negative effects. And I'm wondering about thinking about the integrative care movement as actually creating a social experience for people who come in. They have a team of people, and simply that effect is one of the things that can be curative and healing.
I think that's very well put. I very much agree with it. I often say, the single most important factor in the development of the child's brain is the relationship with the primary caregiver. And so that's a social, Leon Eisenberg wrote another famous paper called The Social Construction of the Human Brain, which was essentially a review at that time of all the evidence about the importance of social connectedness and its stimulation of neural circuitry and all those things. So I agree.
Dr. Beardslee, thank you very much. You gave an amazing plenary today, so I just am so grateful for that. Part of the challenge that I have is that I'm a family researcher, and we've set up lots of integrated care programs in various clinics and communities. When we identify a child, they come in and they're having behavioral issues or challenges, we can clearly see that the parent is depressed. One of the challenges that we have are providers who are leery of us giving instruments out to somebody who's not the patient. So how do we address those challenges in identifying and reaching out to parents if they're not the patient? And the other thing is, I do agree with my colleague Barry that we need to be taking this out in the community, but I also would love to hear your view on how do we begin to do this in integrated care in smaller pieces. Many of our populations don't have the time, the resources to necessarily go out into the community for extra classes or interventions. So how do we package this in a way to deliver it in brief increments in primary care?
Well, I think they're two different questions, but very related. And I think the question about how to engage parents when the child is identified as the patient is actually one that we've been working on a lot recently. In Massachusetts, we do a lot of in-home therapy, which is a wraparound service to try to keep kids in the least restrictive settings. And the state made our program one of the three that they're trying to think about in disseminating widely as evidence-based, and they ask us to work with the in-home therapy teams to see how we could use the family talk training. Well, with the family talk, it is very much about the parents' issues, the parents' struggles. And in the in-home therapy, the child is not only identified, but is identified as a major problem that is in needing very extensive services. And I think the two things we've come to are, one, that being able to be a more effective parent is in fact something that parents want. And so typically the clients with in-home therapy have multiple diagnoses, but they have often PTSD. And sometimes the aggressive behaviors of the children activate the PTSD symptoms, and then there's an overreaction. So we sort of calm that down a bit and begin to say you might be more effective if you thought about this, and this may be reawakening certain things for you. So that we've had success in trying to say, can we find an alliance with, with the need to parent and the need to carry out things. I think it's interesting. I tend to look for things. I'm coming to the second point about pieces of interventions. Trying to look at different literature. So we did all this work on depression, and then we did this big project with the Navy, Project Focus, where we put teams on 21 bases across the Pacific. This is a project run out of UCLA by Tricia Lester, and then we wrote a paper about how we disseminated it. We looked at the HIV/AIDS literature, and there's a famous paper by Wingold and DiClemente, which talks about which interventions are actually disseminatable, which ever get used. The first principle is low complexity. Only interventions that are simple are going to get widely disseminated. So I think you learn something about family. In our instance, you learn something about family conversation, you learn something about depression, you learn something about, and then you can do a piece of it that fits what the client, partner, patient, family can tolerate, but leaves open the way of doing more as it opens up.
We have time for one more question.
Fantastic. Thank you so much for coming here and sharing all your experience with us. I did Coping with Depression course, Greg Clark, in high schools in the 1980s, and was a huge fan, but I worked in high schools that had lots of funding and could afford me. And then I kind of moved into primary care, and I've done research there, and now work as a trainer and consultant, and have a couple of opportunities right now. I work in a pediatric clinic in Yakima, Washington, providing training and program development support. And I am consulting with a large coordinated care organization that shares space with Oregon Research Institute, and have Tony Biglin as my friend. So there's great opportunities. And
Right.
So I have a couple of questions. One is how how to dose it right, because I can't wait to get your book and, to look at some of the research. And my effort is going to be to translate it and go back and try it as a pilot at Yakima Pediatrics in a pathway format, which would involve like screening using the PHQ-2 with parents and child visits, and giving them same-day access to behavioral health consultants who could focus on like further assessment, behavioral activation, and family meetings and family routines, and provide regular follow-up. But any kind of guidance or any kind of ideas about research that would help us figure out that dose that is effective and feasible with resources.
Well, I think you sort of, and the other thing we did in the second IOM forum, there's a tension in dissemination research between following the cookie cutter, that is doing exactly the way the developer did. And probably the most famous intervention like that is David Old's. Okay, very rigorous, you do it the way David says you do it. The other is to say that there are core principles across a set of intervention strategy, and what you're trying to really get at is the core principles. I'm a believer in that second set of strategies. That's why I think a lot, and we've trained, when we trained a lot of people at the South Shore Mental Health Center in Family Talk, they said, oh, this is like, parent-child interactional therapy, or this is like, CBT for trauma. In other words, there's a lot in common across good intervention strategy. So I think what you need to think about is, what are the active ingredients? And then you play with different doses. But of course, the other variable is what the family wants and what the family can tolerate. And that's also very different. But I think the strategy that I'm saying is, you have in your mind an idea of a range of interventions. You engage the family where they are and give them something of what they want and need, and then you keep working with them.
Absolutely, at the time of identification.
And I should say, my friend Tony Bigland will have a book on nurturing out,
Yes.
I think, very soon, and it's going to be terrific.
Great.
Thank you so much.
Thank you so much, Dr. Beardslee.